All right, so for chapter 32, which is burns, the case study goes like this. You were dispatched to assist the fire department with a structure fire at 9116 East Leesburg Way. Within a few minutes, you hear radio traffic from an interior crew indicating they have found a fire victim. The crew members announce which side of the structure they will exit, and you take your equipment and wait for them there. Within a few moments, the firefighters emerge with a child who appears to be approximately 8 years old. She is crying, coughing, and holding up her forearm. As you approach, you can see that the young girl has what seems to be a partial thickness burn to her right arm. So right now, she's tearful and upset. She's alert. Her airway's patent. She's crying. She's tachypnic, but with good tidal volume. And right now, her circulation hasn't been assessed, and her skin is covered with soot. So right now, just before we even move forward, we can say that her airway right now is okay, right? Based off of what?
Crying.
The crying, absolutely, the crying. You need to remember that with kids too, like we don't want to just run up to them and just start getting all in their face. We certainly could. This is a assessment, an initial assessment, just by looking at the patient. What are your priorities with this patient? I can't hear you, Hamilton. Did you
Maintain the airway?
Yeah, airway.
Yep. So always airway, especially, from yesterday, you remember that the airway is going to be one of your big concerns. You're listening for things that are going to give you initial clues, right? Like stridor is always a big one, and coughing and things like that.
What he does, that in his with a truck, broke it half in two, and he needs a body for it. So I told him I'd let you look it over today and let it call him, okay?
Okay. We good? Blake, is Mama listening in?
Yeah, somebody wants to buy a lawnmower from us, and I told her that I had to look at it first. And just staying on
No, I love Mama. All right. So anyways, airway, anything like that, circulation, we want to look one of the most obvious things with a burn patient is going to be, are their clothes still on fire? What should you do if their clothes are still on fire?
Put it out.
Put it out. Don't let them run around or anything like that. Make them stop, drop, and roll. Remove any of the burning process, and then get the clothes off of them and begin the process of cooling the burns. So, what are your airway concerns on dealing with structure fire victims?
Inhalation injury.
Okay, and what causes that inhalation injury?
Breathing in a chemical or a hot air can damage vocal cords, lungs.
Right. One of the big issues is the superheated gases. The superheated gases will cause the airway irritation and severe edema. Also, some of the byproducts of combustion. And then if you read a little further into the burns chapter, as far as inhalation is concerned and all, some of your different compositions of gases, depending on what type it is and its solubility with water, could cause some severe lung issues. Um, I'm trying to get Dwayne in. Okay. I don't know. It's not letting Dwayne in. Okay, I'm sorry, guys. All right. So superheated gases and byproducts of combustion can cause airway irritation and severe edema. It is essential to act quickly if you believe your patient has inhalation burns. Y'all remember this from the scenario yesterday. If you believe they have inhalation burns, you need to understand that this is going to be a very serious issue very soon. The presence of soot or burns around the nose or mouth, singed facial hair, wheezing, stridor, especially stridor, and worsening stridor. Be prepared to provide advanced airway management, and it may not be just simply intubation. You may have to get a little bit deeper into it and you know, consider RSI, or you know, if you consider intubation and that fails, surgical crike or needle crike may have to be your next step. And I know we haven't went over those yet, but we are eventually going over those. So you immediately begin treating your patient who tells you her name is Pamela. When you ask what happened, the patient says that she was playing with gasoline and matches with her older brother, who escaped the house unharmed and now is with police officers. As she reached to light a pile of gasoline-soaked rags, the vapors flashed and she burned her right arm. She is able to talk without difficulty, and there's no indication of burns to her face or airway. She has no other apparent injuries. By using the rule of palm, you estimate the size of Pamela's burn to be approximately 4 to 5% involving her right arm and hand. You administer supplemental oxygen. The rule of palm, how did you do that? How did you come to that 4 to 5%?
Patient's palm.
The patient's palm.
Measure.
The patient's palm, because an 8-year-old versus my hands may be double the size of the 8-year-old's, but it's in reference to their hands. Your partner initiates an IV line in the unburned arm while you remove the remains of her shirt sleeve and irrigate the area with cool sterile saline, and then assess the right arm. Pulse and motor sensory functions are present. So right now, vital signs all look pretty good. Her pulse is 120. Her blood pressure is 116. Her respirations are 36 to 42, but the key here is that they're equal and clear sounding. And her skin's warm pink dry with some soot and skin on the clothing. Why is pulse oximetry unreliable in these circumstances?
Carbon monoxide poisoning.
Yeah, I mean, and that's going to be your textbook thing. Your carbon monoxide, which is, you know, colorless, odorless, and a byproduct of combustion. even some other byproducts such as formaldehyde, sulfur dioxide, nitrogen dioxide, cyanide. Cyanide is really bad, but you know, some of those can displace the oxygen, but carbon monoxide in particular has an affinity for hemoglobin that is 240 times greater than its affinity for oxygen. So it's kind of like the hemoglobin, it kind of likes its oxygen, but it loves the carbon monoxide. The excess CO causes severe tissue hypoxia despite the possibility of acceptable or somewhat normal readings on the pulse oximeter, because the SpO2 is just looking at the saturation of that hemoglobin molecule, or that hemoglobin protein with a molecule. It's not able to tell the difference between O2 and CO2. Are your transport considerations affected by the location of her burn?
She still needs to go to a burn center.
Yes, and why, based off of your burn criteria?
Yeah.
What was the percent of the body?
It's her hand.
It was 4%, but it was her hands. So criteria for transport to a burn center include partial thickness burns on greater than 10% of the total body surface area, any full thickness burns, or burns involving the hands, feet, face, major joints, or groin, burns involving the airway, circumferential burns, and so on and so forth. Her issue here is that she had burns affecting her joint and her hands. All right. What are some of the most common complications? So you've got several complications, but what are some of the common complications that we're concerned of with the acute burn of a patient?
Fluid loss.
All right, we're worried about fluid loss. Definitely. Hypovolemic shock.
Compartment syndrome.
All right, compartment syndrome due to the fluid shifts.
Infection.
Airway
Or-
compromise.
Yep. Let me back up just a minute. He said compartment syndrome, and it could be because of circumferential burns, right? Because circumferential burns, they're going to form that E-scar, right? And they're going to essentially kill the elastin in the skin cells, and they're not going to be able to expand. And so what's going to happen? The fluid, the inflammation is going to continue. They're going to continue to third space, and they're going to start compressing on the muscles.
And
What is,
potentially break through the skin, causing a rupture in the skin.
Yep. Another one that we won't see complications initially, but we have a huge role is infection. Because we want to make sure that they're just like that patient yesterday. He had burns on his chest and all of that, you know, and we were kind of like, well, how are we going to cover him up or whatever? If it were me, I would put a sterile burn sheet on top of it. I wouldn't worry about trying to cover him and all that. I would put a sterile burn sheet on top of him. And then, you know, we want to try to keep infection out to the best we can. And then also thermoregulation, which are all functions of the skin and the barrier that's being burned off. As you're en route to the appropriate facility, your partner works with the local police department in an attempt to contact the patient's parents. One relative is found, the patient's grandmother, who consents to Pamela's treatment and transport. Now, this kid was okay. I mean, as far as like we had time to try to get consent and all that. But number one, if nobody was found, or number two, the patient was critical, what principle would you apply?
Implied consent.
Yeah, implied consent. She's a minor, and we know that the implied consent there is that no reasonable caretaker or no reasonable person would deny treatment for a patient that you know, needs it. The grandma adds that Pamela is normally healthy, no meds or allergies. You address the patient's pain by providing an analgesic. In this case, you decided morphine via slow IV push, elevate her arm with pillows, cover her with a blanket, and place her in a comfortable position. Now, She got burn on her hands. Was the morphine necessary?
Whether
Absolutely.
necessary or not, the pain in a hand is incredibly intense.
Right. So it was necessary. And that's one of your things that we've talked about in your one of the questions in your prep work. What is the significance of pain control in burns? Well, depends on the burn. You know, the worse the burn, actually, the less painful it is.
Because it burns the nerves.
Right. But for partial thickness, superficial burns, that's why like a sunburn hurts so bad, because it's right there on the nerve endings, right? Partial thickness burns. I usually am able to show everybody my scars on my hands, but I burnt my I had some pretty bad burns on those couple of fingers there, and then I had another bad burn from a fire on my arm. But these were actually just from where I forgot all of my firefighter training, and my wife let some frying okra catch on fire on the stove. But
That's just a reason not to eat okra.
true. But anyways, I grabbed the I grabbed the frying pan instead of just throwing some flour or something over it. I was smart enough not to throw water on the grease, but I grabbed the frying pan and tried to walk out with it, and the fire lipped over and it caught my hands there. And so I ended up having some pretty deep, almost 3rd degree, but they were partial thickness 2nd degree burns. But I ended up like I was working in the ICU at the time, and I tried to wrap it up and pretend like it was no big deal, but the ICU is not the place to have open burns on your hands and all that. So I ended up having to go to the wound treatment center, and I ended up getting some skin graft. It was a synthetic skin graft, but okay, Walker lost connection again. But I think my whole 10-minute story there was to point out that it was very, very painful. It was very painful. Anything to do with your hands or feet is very painful. If you've never gotten a shot in your foot, I actually went to the doctor last week. I meant to tell y'all this last week. I went to the doctor last week for pain in my foot. Well, actually, it was just a checkup, but I had a pain in my foot for several weeks now, and he ended up cutting out a big chunk of glass about the size of the tip of my pinky. I had no idea was in my foot. And if you don't believe me, I've got pictures. He warned me. He said, have you ever gotten a shot in your foot? Because it's going to hurt. And I was like, I got shots everywhere. I'm good, you know. No, that was the worst pain I've ever felt. No lie, I've ever felt in my life. And I've had several procedures, even the man procedure, but that was the worst pain I've ever felt in my life. Anything to do with your hands or feet is often very painful. And if you don't think that's true, just get a good paper cut on your fingertip and see how it affects your whole body. So right now, nothing's really changed as far as vital signs go. Are we real concerned about her vital signs?
Not at this point.
Yeah, she's a kid, so that's fine. Blood pressure is actually pretty good for an 8-year-old. Her respirations are a little bit high for her age. And so we want to continue to monitor that. But again, she may just be kind of flipping out too. I would imagine after giving her that little bit of morphine, and I would recommend having an antiemetic close by, especially with a child that's never had morphine. Have that close by too. But I would probably think that some of her vital signs will kind of come on down after that. So, you know, she probably doesn't have a huge risk of going to burn shock, but that's something that we want to be thinking about, right? We talk about the fluid shifts and all that in burns. That's why we do things like the consensus formula and all that. So what exactly is burn shock?
Your body don't know how to regulate its temperature.
Okay, it does have it has a little bit with a regulation of temperature, but it's really more of something else. Remember, shock is bottom line.
Hypovolemic shock.
Yes, we don't change the definition of shock. Shock, no matter what chapter you're in, shock's going to be inadequate cellular perfusion, right? And in this case, it is a hypovolemic shock. Why?
Because they're losing fluid.
Right, they're losing fluid through their barrier in their from their skin. And what happens to the capillaries?
They dry out.
Do what? Say that again.
They weep.
Yeah, the capillaries, they become leaky. They become permeable, and fluid oozes out into circulation and into the interstitial spaces. You've got really three places where fluid can hang out. You've got your first space, second space, and third space. Your first spacing is going to be intracellular, intravascular, where the fluid should be. Second spacing is just outside of those areas, but they're still close by the cell. So if we were able to kind of get the fluid balance moving again, we could get them back to where they need to go. And then third space is where you have all this fluid, it goes to the interstitial spaces. So whenever you have like edema from, like a swollen ankle or a goose, well, not a goose egg, but even say a blister from a burn, that fluid is third spacing. It's going into an area that can't get back into the cell or the vascular space. How long does the process of burn shock take?
Begins within minutes.
All right, it can begin in minutes, but the major fluid shift doesn't occur until about 6 to 8 hours after. All right, so that's why they focus on, remember your Parkland or your consensus formula, right? You get a total amount, and then you give that first half in the first 8 hours. Why? Because it is a proactive approach to what we know is about to happen physiologically. All right. So the capillaries become leaky. So intravascular fluid oozes out of the circulation. Meanwhile, cells of normal tissues take in increased amounts of salt and water from the fluid around them. This process occurs during a 6 to 8 hour period. Therefore, if a burn patient is in shock in the pre-hospital phase, look at another injury as a source of shock. Also, make sure that you auscultate lung sounds before administration of fluid therapy. I said a very important statement right here. If a burn patient is in shock in the pre-hospital phase, now we're not talking about, oh, I'm in shock, I just got burned. We're talking about, oh, I'm in shock, I'm hypoperfusing, okay? Look for another injury as the source of the shock. Also, make sure that you auscultate lung sounds before administration of the fluid therapy. So the consensus formula is we know this to be a formula that we will use to figure out total amount in liters. Well, really it's in milliliters, but we figured out in liters over 24 hours, where we give half of that volume the first 8 hours and the second half of that volume over the next 16. During like a test that you take with me or anything, go ahead and use 4 unless otherwise specified, because the formula is 2 to 4 times the body weight in kilograms and the percentage of the body surface burned. Go ahead and just use 4. Just remember to use 4. I try to remind you because there are, I think, at least 2 Parkland formula or consensus formula, the same thing, questions on the exam, okay? What are other considerations in relation to pain management during pre-hospital burn care?
Repeat the question, please.
Well, you see it on the screen right there. What are other considerations in relation to pain management during pre-hospital burn care? Just there's 2 things that comes with pain management. You need to trust it that patient is in pain with what they're telling you. All right. You need to trust that you don't know their pain, even if you've experienced similar injuries. We've got to be very careful with cooling, because they're going to want maybe ice to help. It feels, help with the burn process or help the pain there. But we got to be very careful with cooling. And we've just got to be prepared to provide that analgesia, okay? It is not appropriate to not provide analgesia for these patients. We don't want to overdo it, and we also need to understand that as providers in the field, we're not going to be able to completely block all that pain, but we need to get it to a manageable level so that we can treat them.
So with the management of pain, would you, instead of giving them the full dose, just give them half of the dose that you would normally give them?
I would just look at if it's a dose range, and then I would just start with the lowest range, lowest part, and then go up.
Okay.
As you arrive at the hospital, the patient seems more comfortable. She's no longer crying and vigorously, and occasionally gives you a glimpse of a smile. Meemaw meets you at the hospital and informs you Pamela's mother is nowhere to be found. You provide a report. I just got so mad at Pamela's mother. You provide a report including the history of events, including your concerns about the home situation to the ED staff. That's something that we've not even really discussed, was the fact that the two kids were at home alone, playing with gas in the house, lit something on fire. The punk brother ran out. I don't know about y'all, but I can tell you this about my son. If he and his sisters accidentally caught the house on fire, I guarantee you he wouldn't leave them. So I'm mad at the mama and the brother right now. I'm digging way too deep into this. So vital signs are looking a lot better. Her heart rate's even come down. So pretty good. What are some other considerations that we must consider with dealing with a pediatric burn patient?
Fluid shift occurs much more rapidly than an adult.
Right, and they don't have as much fluid, right? And so, yeah, it's going to have a bigger stress on the body. Also, their metabolism is much faster. So this is a huge stress on their body, so glucose utilization. So you may need to be watching out for that. Look for signs of abuse. Okay, I don't believe that this was an abuse situation. This could get some eyebrows raised about leaving young kids at home by themselves. It's a different time. When I was little, I mean, I stayed at home by myself from the time I was about 7 years old. But it's a different time now. I would never dream of leaving even my 8-year-old at home by herself right now. Be aware of potential for child or elder abuse. It's your responsibility to report suspected abuse or neglect to the proper authorities. So while we were, I'm just kind of curious here, because I just wanted to kind of elaborate on that for just a minute. But while we were talking about this, did it occur to anybody, or did anybody actually think about the fact that, hey, we might ought to report that situation, that kid situation?
Yeah.
Yes.
That's the kind of stuff you got to keep your eyes open for, and just kind of remember there. Okay. Hey, Sarah Catherine, driving with your sunglasses on.
Go to the beach?
What?
I know.
Nice. Well, I guess you can say that you're kind of taking us all to the beach with you.
Yeah, come on.
I'm so jealous. All right, I'm going to let you drive so that you don't wreck. And if you do, just kind of quietly go off screen so that we don't know.
Just hang up first.
Yes, please, please. All right. So,
Well, they could all use that as an online lab. What are you talking about?
That's true. That's true. Virtual lab. All right. Any questions? about that. All right, so one of your questions on your prep work is was asking about burn centers around your area. And for us, as far as a tried and true burn center, you've got essentially 3 places that would be remotely close to us, and that's going to be Grady, Grady in Atlanta, Children's in Birmingham, and UAB in Birmingham. Now, there's a couple of others. These right here are just, you know, burn centers within the southeast area around our location. USA is in Mobile, and then you see a couple others here over in Georgia as well. But ultimately, that's what a patient needs. And if it's in this area, those severe burns, they're going to go to Birmingham or to Atlanta. We're just, you know, our hospitals here are not equipped to take care of that. Now, something like my burns that I had on my hand, they were equipped to take care of that, but not something that's serious. So just a quick little bit of information here. About 450,000 burn injuries require medical attention each year. Your risk categories here are children younger than 5 and elderly. And of course, we got to think about abuse with that as well. But not every situation involving them is going to be abuse, but you've got to be open for that. Now, the thing is that there's been a better understanding in the way that actual the patho of burns occur. We're developing more information on that. There's actually been, you know, building codes. There's several things that have reduced the amounts of burns every year, but they still occur, and we still need to be aware of everything that we do in the pre-hospital setting could have a huge effect on their overall recovery. Getting them thermoregulated, helping getting them warm, helping essentially what we need to be thinking about is that the skin has 4 functions, which are provide protection from the environment, regulate temperature and fluid, that contain sensory nerves that communicate with the brain, and it aids in healing by responding to injury with inflammation. Now, what we need to do is we need to figure out, hey, the skin may have been compromised, so we need to take the place of the skin in certain areas, helping form barriers from infection. That's important. Anything you put on a burn should be sterile, all right? Helping with thermoregulation by trying to keep them warm. Do not put freezing cold ice packs all over burn patients that have multiple a lot of body surface area burned. You know, something like my hand, I would probably say it was really less than 1% body surface area. You know, you can do that, but you want to try to help regulate their temperature and try to keep them warm. All right. Because of the functions that the skin's going to be losing, and because of the severity of what the burns do to the tissues, lasting effects may be severe scarring, difficulty with thermoregulation, impaired vasoconstriction, you know, inability to grow hair on the injured site, little or no sensation in the scarred area. So, you know, you got a patient like this right here who obviously had some pretty severe burns, and the scarring is not just superficial. This is deep scarring here that affected nerves, tissues, and really just the whole normal skin process and muscle process, right?
Psychosocial stuff.
Yes, absolutely. Their social skills or social, the social effects, not their skills, but their effects, the effects on them psychologically.
Psychosocial, yeah.
You know, there are patients that have been able to, you know, overcome that kind of stuff, but there are patients that, you know, they're very very self-conscious, because it could be very deforming with the burns. And I think that what folks don't realize or refuse to see is that a lot of times patients with severe burns, they're still the same person underneath. They've just got these scars, and so then they end up turning into like Freddy Krueger or what's his Two-Face on Batman.
Scarface.
Yeah, that's it. Absolutely. Didn't he get burnt? So it's really, not their fault for the evil that they end up doing. It's society's. So the main things that we're concerned about acutely, though, is going to be hypothermia and hypovolemia. They're an increased risk for infection and shock. Burns are soft tissue injuries created by destructive energy by radiation, thermal, or electrical injury. All right. And I wanted to mention the hypovolemic shock because this is, things that we're thinking about more on the paramedic level. Hypovolemic shock, as far as with burn shock, is because of two different types of injury. You need to know that. Fluid loss across the damaged skin, like Dwayne mentioned earlier. You don't have your barrier keeping your fluids in. And then a series of volume shifts within the body that do occur at certain times. And so that's why we want to try to stay ahead of the curve by trying to start giving fluids. Now, you've got to replace the fluids. What is the preferred fluid in this?
Lactated ringers.
Yep, Ringer's lactate or lactated Ringer's LR, because it does have potassium in it, and you have potassium issues intracellularly and serum-wise, all right? Chemical mediators are also released, causing possible damage, and then you may even have coagulation disorders depending on the effects of the fluid movement. Remember, DIC, disseminated intravascular coagulation, that you may often see with septic shock or even in severe anaphylactic shock, which will result in emboli, but it will also result in bleeding too. DIC is one of the most confusing and interesting effects that the body has. You start getting because of a lot of things that go into it, but you start getting very small micro emboli or microthrombi on the capillary areas. So either pre-sphincter or post-sphincter, and y'all, I'm still just a little boy at heart. I'm a 35-year-old man, but anytime I hear sphincter or anything like that, there's certain words that I just have to avoid. But they actually cause these microemboli. So DIC is a disorder that, where'd Dwayne go? He disappeared. That causes, we all knew that you weren't at the Golden Gate Bridge, but it causes clots at the capillary level, and then it actually causes bleeding in the rest of the body, which is kind of weird. And might I also add that Zoom has so many freaking distractions that somebody that is ADD like me, I'm ready to get y'all back in the classroom, because at least I have a lot less distractions, because I see y'all's house and I'm like, I wonder if their house is clean, or I wonder if they're like, like piled all their stuff under their bed, or and I'm also always trying to look for that person that's in the background too, that's like got some kind of funny costume on. I'm never trying to look for the naked person in the background, but that'd be weird. But I'm really just rambling right now. Okay, so hypovolemic shock. This is what I was talking about earlier. First spacing, second spacing, and third spacing. And essentially, when we talk about these spaces, we're just talking about the area where the fluid can go, where the fluid will be forced, all right? So if I ever refer to something as third spacing, what I'm going to expect to see or expect to assess is edema, okay? Why? Because if they're in the third space, this is trapped fluid. Basically, the fluid is in a place in the body where it is difficult or impossible for it to move back into the cells or blood vessels without medical intervention. The easiest thing that I can get you to picture is think of a blister that forms, let's say from a bad sunburn. All right, and you had some fluid shift. All types of burns cause fluid shifts. You get that blister, and now it went into the third space, and then it leaked out, and it is being trapped, but there's no way that it's going to be absorbed back into the vascular space or back into the cell. All right. I just wanted to mention with thermal burns, there's several different thermal burns, and you're going to go over all of those in your prep work, and you're going to go over the treatments and all that. The thing, again, that we're worried about with thermal burns, what is you doing, Dwayne?
ADD's kicking in.
I'm going to have to put somebody else over you. Heat energy can be transmitted in all these different ways: flame burns, scald burns, contact burns, steam burns, and flash burns. Look for particular injury patterns, and each one of these are going to cause different types of injury patterns. But this right here, this picture right here, this is child abuse most likely. It's terrible. But this is child abuse. It's one of two things. It's one of two things, honestly, so you can give it a benefit of a doubt sometimes as well. But this kid sat in scalding water. So it could have accidents do occur. It could have accidentally, what?
That kid was placed in scalding water.
Yes, most likely, yes. The only reason why I say you've got to assess the full situation is that sometimes accidents do happen. Because I know of a time where I remember it was one of my aunt's friends. When we were younger, my aunt's like my sister. She's only 7 years older than I am, but one of her friends' little sister actually filled up a bathtub and then put their baby sister in there, and it scalded her because, and it was completely accident, you know, like, so all I'm saying is look at the whole situation. You know, there was just recently, I don't know if y'all saw this, and this is a little bit off track here, but just recently there was a father whose 2 children were found in a truck that had died from heat, and he was arrested for abuse, but then they actually pulled the footage, I guess the home video camera or whatever, and showed that the children actually crawled up in the truck on their own and got stuck in there, and it was never his fault as far as negligence goes, you know? So all I'm saying is that you need to be, you definitely need to be on your A game. You need to be looking at this stuff. Yes, Leanne, I do agree that this had to have been, right? Somebody, the kid was placed in there, okay? So with child abuse, what you're looking for is formed shapes or unusual patterns, cigarette burns, things like this. Also stocking burns, what they call it, where you actually, it looks like stockings up their legs. I just, you know, my kids, they drive me nuts. Like, and we get into it, we punish, we teach, you know, lessons, but never in a million years would I ever consider doing anything like that, you know. That there is just, anyways, we'll talk about that more in pediatrics. All right. There are 3 burn zones, and you do need to know these. You've got your zone of coagulation, your zone of stasis, and the zone of hyperemia. Now, if you think about on a burn, hyperemia, that's going to be a large amount of blood in the area, so it's going to be very red, okay? So essentially think of it as almost like a bullseye, okay? Your zone of coagulation, that's where the damage, the tissue damage has occurred. The zone of stasis is where you've got decreased blood flow from the inflammation, and it may actually see tissue death within that. And then the zone of hyperemia, this is typically where we don't have or lasting effect, and usually the cells will recover within 7 to 10 days, okay? As far as burn depth, now understand this, you really have more of a responsibility, of figuring out body surface area, total area, than really that to really get into the burn depth, because you can look at some and probably determine, hey, this is, you based off of some of the criteria. Like a lot of times you can look at a superficial, which is going to be like your sunburn or something like that, you've got your superficial, and then you've got your partial thickness, and your partial thickness is going to usually be where you start seeing blisters and all. So if you've got your sunburn and it starts developing blisters, which does occur, that could very well be almost a 2nd degree burn. All right. Your 3rd degree, this is going to be where it goes past nerve and tissue. So typically the immediate area around that burn, especially the zone of coagulation and probably the zone of stasis, are usually not going to be very painful, okay? And that's where your thermal burns, your inhalation burns, those are a big concern for us because of the inflammation and the continued inflammation that can occur. And also remember that your airway with burns, once it starts closing off, you don't have, really the resources that we make it seem like you have in lab, meaning that you're not, as entry-level paramedics, or heck, I'm not either, because I'm not critical care certified, going to just be able to up an RSI patient in the field, unless you're in an area, and it's not in Alabama, but you're working in another area that is part of your normal patient care protocols. All right. So what that means for you is that you really, really, really need to be very much in tune with that airway. And let's say from that scenario yesterday where the guy was already stridorous and we felt like his airway was going to be compromised, we either need to go ahead and get him to the hospital quickly, or we need to call the helicopter, because they've got additional resources that we don't have in that situation. All right. Superheated gases really cause some big issues. And it may just be steam. Whoops. Hold on just a minute. Again, distractions. All right. And then carbon monoxide poisoning, it may not cause like the inflammation, but we are worried about the oxygen displacement. All right. And then, of course, put out the fire if the patient's still smoldering. Make sure, and y'all laugh about that, but I have seen situations like that. I have seen literally some crappy medics that have loaded folks on the ambulance with their clothes still smoking. Pay attention to your surroundings. Make sure that you may not be in the immediate area of burn, but you may be in the immediate area of toxic gas or something like that. Okay. Uh-oh. To intervene early with the airway, please make notes of this. This is probably the most important when it comes to initial management of burns. pay attention to the sounds that you hear even before you assess with a stethoscope. All right. When you do assess, you need to assess lung sounds early, and then you also need to listen to tracheal sounds by placing your stethoscope over the larynx, trachea area, because Strider's not always going to be very super audible. Most of the time it is, but you want to be able to hear if you can. If you hear wheezing, if that's affected, they may respond to beta 2 agonist. But you need to note if there's any signs of pulmonary edema, because remember the whole process with pulmonary edema, you got cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. And non-cardiogenic pulmonary edema, and this goes back to last class, non-cardiac pulmonary edema is often going to be caused by what? Inhalation of toxic substances, okay? Now, if you, as far as inhalation injuries are concerned, if you look on, where's that chart at? I don't see it right now. But there was a chart somewhere that talked about the gases and things like that, and their effects on the body, and it all depends on several different things there. All right. Circulation during the first 24 to 48 hours of burn care, fluid resuscitation is emphasized. It's proactive. The Parkland formula, it is proactive. Burn shock is a result of hypovolemia caused by the fluid shifts. Large volumes of fluid are not needed during the first minutes of pre-hospital care unless the injury occurred some time ago. Don't delay transport trying to get access. Get IO if you need it, but we don't have to dump loads of fluid into them initially. If you don't have time to figure out the rule of nines and all that initially, just get an IV and just get fluids rolling. All right. There are apps out there that will figure this stuff up for you, though. Okay. You need to know how to do it in class and all that, but it's a very good idea to have some kind of resource that's going to help you figure these things up. Okay. The rule of nines, make sure you know, though, you know how to figure that up. And we went over that in lab yesterday. The Lund-Browder chart, it is a more precise method, but it is cumbersome. It takes a while, and it is not very good for pre-hospital quickly measuring, okay, because it's in very small percentages, and you've got to figure out each region of the body in a little different way. Now, the most easy one is the rule of palms. The rule of palms, that represent 1% of the body surface area, helpful when the burn covers less than 10% of the body surface area. Now, this dude, I don't know how we would really figure that out. Hopefully his other hand is in good shape, but that one's not. If you don't get the joke, he's from Scary Movie 2.
Oh, man.
His other hand is good, by the way.
Your
But it's not his
classification
strong
of burn
hand.
severity, this is going to be published by the American Burn Association. Your major burns are going to be very important for you to identify. And remember that special populations, such as younger than 5 years, all right, so let me point this out to you if you've not looked at this. This one right here, you need to definitely pay attention to. Burns on patients younger than 5 years old or older than 55 years that would be classified as moderate on young adults or adults 54 or, I guess, younger. Why? Because of what we had talked about earlier. Metabolism issues and development issues with children, and really metabolism issues and the ability or inability of some body systems to process as quickly in the older patients, okay? with your airway, there's 4 categories of airway that you need to be watching for these burn patients. Patients with acutely decompensating airway who require field intubation, patients with deteriorating airways who might require intubation, patients whose airways are patent but have history consistent with risk factors for airway compromise, or patients with no signs of or risk factors for airway compromise who are in no distress. So in your scenario yesterday, where did that burn patient fall in?
Deteriorating airway?
I can't hear you, Hamilton.
Deteriorating airway.
Did my thing go mute?
I don't know.
A deteriorating airway.
Did anybody deteriorating?
Can y'all hear me?
Yeah.
Yes.
Yes.
Okay, for some reason my whole computer went mute. I thought that I had solved that problem. So what was the question was what
His airway was deteriorating.
so you would say he was in the second category? Yeah, and I think that it's a situation where you need to just be prepared. Period. And I think yesterday, now I didn't see everybody. I did see Blake in his group when they did the scenario, and they made the right decision early. So the patients with deteriorating airways who might require intubation, these are the ones that probably, if we got that gut feeling, we probably need to just go ahead and RSI. Because if they go into where they absolutely require it, then that means that you've probably lost airway, and the next step is going to be a crike, and that's something that's really a pipe dream for us in some situations. All right. Your fluid resuscitation, 20% of the total body surface area fluid resuscitation is needed. So really and truly, the little girl from the scenario, she had 4%, and they, I think was there partial thickness burns. We really don't have to worry about loading her down with a lot of fluids. But you need to know this Parkland formula. I know they went over it with you yesterday. And then pain management. Narcotic analgesics should be administered judiciously, meaning that we need to be careful with them, but we don't need to withhold them. Okay.
With pediatrics, would you rather give morphine or ketamine or fentanyl?
I would probably say, I don't know, really and truly. I would probably say ketamine would probably be the safest bet, would be my guess. But I'm not real familiar with the actions of ketamine with pediatrics. But I would like to become more familiar with it. Okay. All right. And then always, this is a very, very key word here, guys, or key phrase. If an acutely burned patient is in shock, look for another injury. Why? Because it takes time for the fluid shifts to occur for the burns itself to cause shock. Okay. I just listed out the types of burns here. One thing I want to point out with electrical burns, the most common cause, or there's 2 factors that lead to causes of death in electrical injury. And it's not going to be because of the electrical current passing through the heart. It's going to be what?
The cardiac dysrhythmias in the causes.
Well, on page 1662, and this is I'm giving y'all a lot of answers for the preload work and all that, but asphyxia may occur when prolonged, or the two most common causes of death from electrical injury are asphyxia and cardiac arrest. Asphyxia from prolonged contact with alternating current causes tetanic contractions of the respiratory muscle, meaning that it just kind of locks it up, you know, when you're like, and very tight. You want me to do that again? All right. And then cardiac arrest, which is going to be secondary from hypoxia, or like Leanne said, as a direct result of the electrical shock. But most often it's going to be asphyxia or cardiac arrest from the asphyxia. Okay. Know your types of radiation or the three types of ionizing radiation, which are your alpha, beta, and gamma waves, and know the difference in those. Don't just bypass the radiation stuff because you may say, hey, it's not very possible that we're going to see that. Here's one thing I want to mention about radiation burns, though. You very well could come in contact with somebody that's been exposed to radiation. You're not going to see the effects of that initially. Radiation burns, radiation illness, radiation sickness, it occurs over time. Chemical burns, though, you will most likely see very quickly, okay? And then chemical burns to the eyes, you want to make sure that if they have contact lenses, that's the only time you would remove a contact lens in the field, okay? And then remember, I showed you guys the Morgan lens last with ears, eyes, nose, and throat. If you didn't see it, look up the Morgan lens, and that is a actual device that we can use that you hook up to saline or fluid and put the lens over their eyes, and you can do copious amounts of fluid. So your as far as chemicals are concerned, though, your protocol for chemical burns is going to be initially copious amounts of water. All right. Be sure to irrigate very well, especially in burns to the eyes. Okay. And then if it is a dry type chemical, you want to try to brush it off and then flush with copious amounts of water. Never ever try to use the chemical antidote. Our antidote is going to be overpower it with water. Now, you do run into some situations though. If you look on page 1657, I'm not going to go through all these, but there's several types of chemical burns that require special management. Dry lime. Dry lime is an alkali burn caused by the dry lime in combination with water will produce a highly corrosive substance. So in this situation, somebody that is covered in lime, and not like the lime you put with your coconut, you need to try to remove the clothing and brush as much of it off. Then try to get as much of the lime off of them and then flush with copious amounts of water, okay? And then they've got hydrofluoric acid. Good Lord, if they're burned with that, my goodness, it's not good. Calcium gluconate gel is preferred treatment for hydrochloric acid. That's the kind of stuff you'll see on registry that you probably will not have calcium gluconate gel in your drug box. But if you see hydrofluoric acid burns, you know that you need to cover it with calcium gluconate. All right. So anyways, be sure you look over some of those things like the lightning injuries, radiation burns, and chemical burns. And that's why we're doing some of that prep work as well. All right. So that's your burns. So what time is it? 9:42. Perfect. Good timing. All right. Let's take about a 5-minute restroom break, and then we're going to go through face and neck trauma. Face and neck trauma, I'm going to do the case studies, and we're going to do some discussion questions on that, and then we're going to move on to spend a few minutes on head injuries, okay?